So now we've had our nice break and you've had your cup of tea.
Thanks, sir.
We will continue on with just a reminder about our rights. As you know, it's one of those things that I'm very stuck on. So we've got to make sure that we give the right medication. It's really important. And the important thing about all of these rights is that one of my jobs has been to investigate medication errors, and out of the couple of hundred that I've actually investigated, it's always one right has been missed. Never investigated a medication error where everybody's done the 7 rights and got it exactly right. And I'll be honest, I've made a medication error myself. I accidentally gave a medication by the wrong route. I gave an oral medication when I should have been giving an IV. I was with a student, talking to him, distracted. Oh yeah, that's right. Popped it out, did all the checks, had the right person, everything else. Never looked at that route. Gave it to them, oral pills. They had it, and I looked back down, and I went, and it said, should we give an IV?
They were in pill form.
No, yeah, but there was an IV, there was IV, and there were pills. I was doing all the pills. The other girl was actually doing the IVs. So I went and said to her, don't give that IV. I've just given it oral. I rang the doctor and said, look, this is what I've done. He said, don't worry. He said, I'm on my way up to the ward. He said, I'm about to change all that for him. But in saying that, I still put in a medication error form. I still did a report on myself because that distraction is what caused it. That was my fault. I allowed myself to be distracted. Nothing ever came of it. No harm was done to the patient. But it's still a recognised issue, and it's reminded me about how important those rights are. So it's really important, right? And we do a check on our patients. And remember, when you go to check your patient, who wants to have a go at how you'd introduce yourself to the patient? You've never met your patient before. You go through the door.
What's your name, David? And you've got the allergies.
Yeah, so introduce, hi there, don't call him by his name, because then he's got a trigger to who he should be, in case he's a little bit confused. So it's, hi, I'm Neville, I'm here to give you your medication. Can I just check your name? Check it against your documentation. Check it on his armband, make sure it's right. Alright? And in this step, while you're checking they're right, that it's the right medication, we do an expiry. Check the expiry date. So, where do you find expiry dates on your medication?
On the box. Or on the bag.
So, pharmacies send it up. They don't want to give you 100 pills because they can distribute it out and not waste as much. They just send you the foil. Should be on the...
Yeah, it's on the pack.
So, my pharmacy's really clever, right? And they thought, you only really need 7 patients because this patient's only in for 7 days. And they've cut off the date. What would you do?
Bring him up.
I don't know.
Would you administer the medication?
No.
No, exactly. You would send it back to them because it's one of the rights.
Right.
Or one of the checks.
I know.
The right dose. So we've got to know our mid-calcs to be able to calculate. Check your dose, recheck it. 2 people. If there's 2 people checking the drug, they should both do a separate calculation. And don't confer with each other because there'll be no point in doing separate.
Can we do that in the exam?
Yeah.
Good thought, no. So check your packaging. Make sure you're getting the right dose. Because you might think I've got a tenolol 50 and you might have pulled out 25s because they're all in the tenolol drawer. So check it. So you've got to make sure you've got the right person, and we talked about introducing ourselves.
Yeah.
Ask the client to state their name after you've checked their name bag, right? And address the client by name then. That's okay. And remember, you can give them 4 or 5 medications at the time. You don't need to check it each time. But if you walk away from that patient and you come back with a medication, you need to check it again. So you give their orals and you go out, you get their IM from there, you still got to check it, even though it's just the right thing to do.
Yeah.
Every time you give that medications, the 7 rights. Okay. The other thing we need to check on all medications is allergies. Just because it's not written in there, don't assume that they don't have an allergy. Because in a lot of them now, there's a box that they tick that says no known allergies. Right? This one.
It's underneath your arrow. I can see it.
There, it's been ticked. Right? Nil known allergies. Even if it's on there, I still ask them if they've got allergies. Because all of a sudden they might remember one they had. And it does happen. I've given morphine and Maxilon to a lady. The consultant I was working with ordered it. He said to her, "You allergic?" "Nah, I'm all right, mate." "Good. Neville, can you go and get us some morphine Max? Here's the order." Came back, gave it. She said, "You know, I am allergic to something." I was a couple of... morphine and Maxilon. I looked at the consultant. He's looked at me and gone, "Neville, here's an order for some reversing agents. Off you go."
Far out.
So she was allergic to them. She started to react to the morphine fairly quickly. So we reversed it all and gave her an alternative later on. She'd just simply forgotten. She hadn't had it for years and years and years. Accidents happen. Luckily, I was glad it was the consultant was there. It didn't make me feel quite so much of an idiot either. So, the right route. Make sure that we're giving it. Remember my example. Check it. If you suspect that it's the wrong dose, the wrong route, don't give it. Talk to your RN. Talk to your doctor. Check that it's right. If you're wrong, so what? Right? So
You'd rather be wrong than...
I'd rather be wrong than kill someone.
If in doubt, we used to say on the plane, chuck it out.
Yep. And that's a really good thing to keep up with. With the right introduction of the NIMC, the box between the pages, right, recommended administration, right?
Yeah.
We now say you have to give a time to the doctor. So instead of the old BD and you hope to guess when you're going to give it, I say to the doctor, "Can you write down the times, please?" Because we used to go, they used to give it daily, right? And they'd say to us, "Yeah, just once a day." And they'd come up at 10 o'clock, "Why isn't this drug being given?" "Well, it's daily. They gave it at 2 o'clock down at ED. It's going to be given at 2 o'clock today. I wanted to give it at 10. Why didn't you tell us that? Where is it in his note?" So now it's on the chart.
And they have to do that, don't they, now?
Yep, that's their requirement. We don't fill it in anymore.
Yeah, okay.
When they first came out, we were filling them in to suit the ward times. They still want, so we said you do it yourselves. And it's actually part of the rules that they have to do it themselves.
Good idea.
Yeah, oh, it is. It is. So, the right reason. So, why are we giving this to our patient? And one of the big ones is antihypertensives. Right? Why are we giving it to the patient? So, we're going to give them an antihypertensive. We should do a blood pressure, shouldn't we? So, what do you think is a low blood pressure on a patient?
94 over 45.
Yeah, that's a low blood pressure. So what they say is if a blood pressure is below 100 on 50 or 100 on 60, there's normally a local policy on it.
Yeah.
You do not give an antihypertensive without checking with the doctor. And you get, if he says go ahead and give it, you get another RN or another person, RN, to listen. Are you happy if we give this drug? Double check it. Because let's face it and be honest about it, in a court of law, that doctor, if something goes wrong, won't be standing beside you.
Yeah. Yeah.
He won't be saying, "Oh yeah, I told her to give it."
No.
Because it's not
Right.
documented.
It's not documented, it's not done. Yep. So you get someone else to check it so they can support you and say, "Yeah, I spoke to the doctor as well, and it was ordered." So, and that's what we're talking about. A beta blocker, right? A low, right? Check your blood pressure. I've had an incident where the nurses pressed the emergency buzzer while I was on the resus team, came in, and she said, his blood pressure's 70 on 40. And I went, do you know why? Don't know. No idea why.
Yeah, you're given a beta blocker.
Anyway, I looked at their odds and they'd been averaging 100 on 80, 100 on 70. And they'd given them 2 antihypertensives with their morning medications.
Oh, wow.
Just for discussion's sake, can you just define beta blocker,
Beta blocker.
please?
Beta adrenergic, it blocks the beta adrenergic receptors. On the little charts we give out, and anybody who wants those, give me a call and we'll get you a copy. We have lots of hard copies here. A lot of the guys down in Lismore, someone's collected a few for them. But it blocks it blocks your adrenergic, the release of adrenaline. So then your blood pressure doesn't go up because that's what drives your blood pressure up. So it blocks the ability for it to release that.
Yeah.
And that's what
certainly
they call
does.
beta blockers. Atenolol
Yeah.
is a common one. Metoprolol. Okay. So we'll talk about diazepam, right? We give diazepam, right? When wouldn't we give diazepam?
Yeah.
When do we not, or when do
Not
we?
not give it.
We don't give it if they have high blood pressure.
No, diazepam.
Oh.
You have a look on your list. It's a PAM,
Oh, if they're anxious.
right? If they're
If they're
anxious,
highly
it's an
strung.
anti-anxiety drug.
Yeah.
So what if they're unconscious?
Well, that's not, it's going to put them down.
If it's ordered and they're out there semi-conscious, they've got a poor GCS, Glasgow Coma Scale. You know what that is? GCS is their level of consciousness, and it's on a scale of 15 to 3.
Right.
And if you're 9, normally you're not awake.
Oh, no,
Right.
it's one, it's okay.
So 15, you're meditating, normally you can answer questions, you can move around. So if they had a GCS, they probably can't swallow, right? But if they're unconscious, why give them something that's going to make it worse?
Yeah, knocking out, right.
So you have to think about what we're doing.
I wouldn't even consider giving diazepam to someone unconscious.
Some people do. It's a routine order. They're task driven, I have to give it. The right documentation. It has to be on a proper medication chart. It can't be a note given by the doctor here. Give them some diazepam, I'll write it on this bit of paper for you. Right? It's got to be on a proper medication chart. Whether you're in aged care, whether it's rehab, whether it's acute care. Okay. Something to remember.
Do you have the right medication? Do you have the right patience and the right time? Are you sure of the right route? So soon as you now, you sure gonna have to tell how many things you before you give up your shots. Make sure to double check the packaging, 'cause when you have sure there's something you don't know that we should ever, cause you can bring the world before, cause how you gonna fix things, how you gonna fix things, how you gonna fix
Good on them.
Very well done. I just like it because it's a good song. It's got it very poignant. So, along with everything else, we've got to make sure we have valid orders, right? They have to be able to read them. You can't negotiate what the drug you're going to give is. It's got to be the drug you're going to give. And it has to be clearly printed. If it's not, go back to the doctor. Say, sorry, I can't give this drug unless it's clearly written. So, they won't be happy about it. Yeah, they will, because they want that drug to be given. And if they want to argue with you, you take that next step up. I use my positive tones. Would you mind rewriting this order? It's not clear. Sorry, look, rewrite the order for me, please. It's not clear. Look, I'm not going to give this medication until that order's rewritten. All right, look, I'll go to your consultant and get him to rewrite it then.
And he doesn't want that.
No, because the nurse has asked, and to be honest, most consultants understand that nurses are the people giving the drugs and they want them to work with them.
Yeah.
And it is a team thing. They might be embarrassed, but wow, they're going to talk to their registrar of residents and say, just do it.
Yeah.
So remember, they've got to have their proper details on it. It has to match their name band. And it must be ordered, dated and signed by a medical officer, except in the case of phone orders, where it's then witnessed by 2 RNs, given, and it has to be signed within 24 hours.
Yeah.
If it's not, then the consultant's called and then they rapidly get up there really fast, because it's normally the nurse unit manager that accounts for that one. So there are different types of orders. Would you ever give something on a verbal order?
No.
But you'll get them. Occasionally they'll try it. In ED they do. Oh, can you go and give them a bit of heparin? Or 5,000 units of heparin. Yeah, sure, no worries. When you've written it down. You will get telephone orders. Right, signed by the MO in 24 hours. PRN is an as required order. It's still on a medication chart. Standing orders, routine orders that are written out. Standing orders are often in surgical patients. The surgeon likes this and this given, but they still have to be written out by the surgeon or by his registrar. So he likes Clexane given for the first 7 days post-operatively. And that's a standing order from that surgeon, but it still has to be a signed valid order. A stat order. Give it now, we need to. Adrenaline. Right? The MO signs it while you're giving it. But you want it there in front of you to give it. And once only order. They're on the back of those NIMC charts, national medication charts, right? There's a once only order. It's only once it's signed off, that's it. Abbreviation. Here's some abbreviations you may see. Any ones here you think probably are not right? Any ones you don't understand?
Probably the bottom.
2? Yep.
Yeah.
They are very old-fashioned orders.
Yeah, so every 2 hours is 224.
Yep, absolutely. And the other thing is, what's the other thing we've got on medication charts now? Time
The
blocks.
time blocks. Yeah.
So they can write in, okay, 8, 10, 12,
Yeah.
1400. So 2 hour, but they'll write 2 by 24 exactly, or 8 by 24, 8 hour. TID or TES,
Yeah, 3
Right.
times, yeah.
they're not accepted. It's normally TD or 3 times a day and type, put in the times you want to give it. Knock day's common, Manay's still common. They're older terms, but
Yeah.
they're still about.
AC,
BD,
yeah,
BID
AC
is not
and
accepted.
PC.
I haven't done PC.
And
AC and PC.
yeah, before meals, still used by some of the older fashioned doctors.
Yeah.
That's what time's for. But particularly it used to be with insulin. You used to have to give it before the meal.
Yeah.
But with the new faster acting insulins, you give it with the meal, otherwise they crash before they get their feed.
Yeah.
Subtle hint, 7 rights, 7 rights, 7 rights, 7 rights. Okay, things that we have to think about. There's always potential risk when you give a medication. So side effects. Given a drug, you want to know what the possible side effects are so you can countermand those side effects if they get them. And then you know it's from the drug, not from other treatments. Adverse reactions. What they can break out in hives. Giving an IV slowly, you see them start to break out in hives, we stop, and then we call someone, we don't give it again. Anaphylaxis. You don't even know what anaphylaxis is.
It's an emergency.
Massive allergic reaction, your airways close up, you have an anaphylactic reaction. Your whole body's a systemic reaction. Precautions, so read up the precautions. What are the things? One of the precautions is IV, give it over 10 minutes, or give it in 100 mils, or give it with food. Contraindications, when shouldn't you give it? And 2 of the big contraindications are renal function, liver function, and the 3rd one could be pregnancy. Shouldn't be given it with those conditions in mind. Doesn't mean you can't give it, it just means that you shouldn't give it.
Or with other medications.
And you point that out to the doctor who's ordered it, the prescriber. This lady's actually pregnant and it's not recommended for pregnancy. And sometimes it's not recommended in certain trimesters of pregnancy.
Will that be in the notes though? Would that be in
That will be
the
in your
client?
book, in your medication book.
Yeah, no. So say for example a doctor is given prescribed a medication for somebody that's pregnant,
Yep.
and usually that doesn't happen. Usually
Yep.
that medication is not given.
Yep.
Would it be in the notes that he's aware, like he knows? Otherwise,
It should be that they note that it's pregnant, but you don't know that he's aware of the drug's not recommended for pregnancy.
so you do it every shift if it's a
Now, once you followed that up, right? Once you followed that up with him, you say, okay, this is not. I understand that, but it's only during their 3rd trimester of pregnancy. I'm aware that she's pregnant and that it's not recommended for pregnancy, but these are the reasons why we're giving it. That's fair and reasonable. Note in the thing, contacted Dr. Smith,
Yeah.
is aware that the patient is pregnant, has authorised the medication to be given.
Yeah, okay. Yeah.
Heard by 2 nurses.
Heard
and so
by
on.
2 nurses.
And that I would get a second nurse to listen and say, okay, can you repeat this to the nurse for me? Both of you sign the note.
Okay.
Okay? There are a variety of routes we can give the drug. So it's good to know the terminology. Enteral, oral, sublingual. And it's not SL anymore, or it's not SC, it's sublingual, some cut. Because they are easily confused by people with poor writing. I've seen a nurse go to give someone heparin under their tongue. Don't do that. Because she's a task-orientated nurse who was in a bit of a rush. And I've gone, what are you doing to my patient? Because she's got the little syringe there with the heparin in it. What are we doing with that? I'm just going to pop it under their tongue. Why are we putting a liquid under their tongue? I'd never seen that before. Oh, it's something new. What are we giving? Heparin. Okay, can we not give my patient any heparin just for the moment? I just want to clarify the order. When the doctor said, why have you ordered sublingual heparin? He goes, I've not ordered sub, I've ordered it subcut. I went, can I see the order? Grabbed off it. Said, well, it looks like sublingual to me.
Yeah.
But she should have used her common sense. She was a junior nurse.
Yeah.
So I went, no, let's just rewrite that. And since those days, and not
She
because of
obviously
that
didn't consult
incident,
her book.
because of lots of similar incidents, it is now written as subling or subcut.
Yeah.
Okay, IM's written as IM these days, not AMI. Same as IV, it should be written as IV, not IVI.
Mm-hmm.
Ocular, if you want it in their eyes, it should write eyes
Mm-hmm.
and ears.
Yeah.
Transdermal or dermal is skin,
Skin,
applied to the skin. Intranasal, up your nose. Inhalation, so puffers. So you see the term puffer, that's actually not a root puffer,
Yeah.
right? You know that it's given that way, but they should say inhale. And you can give vaginal, and drops is not a valid route either, because it could be drops in the ear, drops
Yeah.
in the eye.
Drops under
Yeah, exactly. So you need to clarify what the route is. Just so it's a quick, you'll learn this more when you do medications.
Yeah.
The difference between intramuscular is it goes at a 90-degree angle into the muscle. Subcutaneous into the subcutaneous fat layer, 45 degrees. IV goes in at roughly 10 to 30 to 10 to 60 degrees. Goes in and you're trying to get a vein deep down in the muscle under that subcutaneous layer. They're a lot longer.
Mm.
And you go in and you're waiting for that flashback of blood to give it. But you'll learn a lot more about that. Oh,
7
it's
right.
popped up again. I wonder why. That's how important it is. Okay, so subcutaneous, it just explains those a little bit better. Gluteus maximus, the big muscle in your bottom, they don't recommend it anymore. Why do you think that?
Because it's fatty.
Nah,
Oh.
because of your main
not because
artery.
not because the average Australian's got a big bottom.
Your artery.
No, there is.
Prosthesis.
There are good point. Fake bottom.
Me.
Down both sides of your buttocks runs your vagus nerves,
Nerve, yeah.
nerve.
Yeah.
and often they've been hit.
Here.
And it causes a lot of pain, and
Yeah.
it gives people nerve damage down their leg.
Yeah, yeah, it makes
And
sense.
it takes
yeah.
a long time to recover if they do recover.
Yeah.
So it's where possible you avoid it. So they recommend your upper outer thigh. Jade will go through all that in length.
Yeah.
Or up in your deltoid muscle, right?
That must be the 2 fingers down.
Mm.
2
Yep.
fingers down the hip
Yeah,
and a quarter of the way.
she'll explain that how they do it. Yep.
No, subcast.
So we're going to quickly, a reminder about there are different classes of drugs. You've got classes of drugs there. These are the other classes of drugs that you need to think about, because I believe in one of your assessments they talk about classes of drugs.
Oh, that exciting.
Calculations, I've said we won't go into calcs because you're going to do them with A-Level. But how you think about your calculations is up to you. A-Lean teaches stock strength over stock required over stock strength. This one talks about dose required, dose in stock. And me, being the simple soul that I am, it's what you got over what you want.
Yeah,
That's how I think about it. That's how it goes
Yeah.
through my head.
yeah,
And that's how I write it down.
Yeah.
When I had to come to formally teaching a class, I thought, oh, I can't write that up there.
mm.
So I had to go to Alien and say, how do I think about this properly? Because I blanked, I went to that board there. And I went, oh, how can I write what you want over what you got? That doesn't sound very professional. So I said, well, we'll go to Aileen's office and have a little chat. And she
Yeah.
taught them.
She's a literacy one too, see?
Yeah, well, it was rather a literate way to put it up there if I had it.
And she told me what you want over what you got.
Yeah. Yep. And it depends on how you think about it. What goes through your head, formal or informal,
Doesn't matter.
right? lots of little hints, bit of metric conversion, she'll teach you all that. She's got cards on that. Calculations for liquids. Paediatric calculations, I'll teach you a little bit about that. We do a body weight, body surface calculation that's used in neonatal intensive care, but it's part of the course that they want us to teach you, so we teach it. But the calculation's down there for you to follow. If you follow it and you don't change or turn off your calculator when you're doing the calculation, you'll get it right. If you change and you stop and it'll get the calculation wrong. And there's an aged care one we teach as well. Paediatric examples, it's the same as an adult. Divided doses, same principles. Just smaller doses, and it's important that we get them right. It's the same as if you're doing an adult. Oh, back again. Our 7 rights. Do you think I'm being subtle?
A little bit.
Ah, good. I'm pleased about that.
What are you trying to
It's
say?
starting to get annoying.
Good. If you're irritated, you'll dream of the 7 rights.
Right.
Neville, can you just tell me what the 5 rights are again?
One of the rights is you're not allowed to injure students.
Sorry.
The right
That's
to injure
all right.
students.
Yeah.
We can't help it if you're slow.
I get it.
Okay, intravenous therapy.
Right.
Talks about, right, intravenous therapy. And here must be able to obviously read a fluid order. It's pretty important that you know what's on there, you know what they've ordered, right? You must be able to calculate IV rates, because although you can't give an IV fluid, you must know what the rate is, so you can check them and you can stop them if they're at the wrong rate. So if you don't know what the right rate is, you won't know whether they're getting the right amount of fluid. And IV fluid is just as dangerous as a lot of medications. And even when you're giving IV fluids, use your 7 rights. Must be able to document in a fluid balance chart. The previous group has asked me to run a little tute on fluid balance charts, which I'm going to do.
Should see the one we used in AQ. Oh, that was special.
So we give IV for different reasons. If they can't give them something orally, they want medication, we can give it IV. Right? We need electrolyte replacement, it needs to be given IV. We can't. Oral electrolytes are chewed up, it doesn't matter what, you can't give them Powerade for everything. And if they're on IV antibiotics, normally they'll get an initial dose IV, then they'll commence them on the oral and send them home. Pain management. This is another one of my, along with the 7 rights, one of my big bugbears about nurses. If patients have pain, they have pain. That's their reality, right? Who are we as individuals to judge someone's level of pain? If they say it's 7 out of 10, it's 7 out of 10. We're not trying to judge how much pain they have really by scaling. We're trying to work out where they are with their pain. But the important thing about pain scaling is to see if what we do for them works. So if they come in and say, I've got 4 out of 10 pain, so I'll say, oh, well, I need to give you some Panadol, right? It doesn't matter where, if they say I haven't taken it, don't be judgmental. They might have not taken it for a reason. Right? So we give them some Panadol and it goes to 1 out of 10. We've been effective. But if it doesn't move, then we have to consider another alternative. So in Oscars, as in out in practice, if you give someone something for pain, go back and check and see if it's effective or not. Half an hour later, how's that pain going? Oh, it's gone to 4 out of 10. Well, we need to think about what else we're going to give you. Are you comfortable with your pain? See how they are? Different tolerance levels. This is a little bit funny but very true.
What can I help you with today? I am having severe pain. On a scale of 1 to 10, what would you rate your pain? Oh, 10. You don't look like you are in that much pain. So, 1 is like you aren't having much pain and a 10 is like you are having the worst pain of your life. So what is your pain? 10. Okay, so a 10 is like you are rolling on the ground in pain. So what is your pain now?
It hurts a lot. It's definitely a 10.
I don't think I'm making myself clear. You look perfectly fine. You are not even wincing even a little. I've seen people lying on the beach look like they are in more pain than you are.
Well,
A 10 is like you've just fallen off a building, or have just been hit by a car going like 50 miles per hour, or something like that.
yeah, I feel like that.
Really? A 10 is like your limb is being chewed by a wild animal, or you've been beaten for an hour by the Bloods and the Crips both.
Wow, it's like you are reading my mind.
Right. A 10 is like a boulder has just fallen off a cliff and landed directly on your head and crushed every bone in your body. Or, have you seen Braveheart?
Yeah.
A 10 is like when they tied a rope to each of his limbs and pulled each rope in different directions. It's like the worst torture you can imagine. It's like being eaten alive by fire ants. Like being burned alive. Like having root canals in each of your teeth without any anesthetic. It's horrific. You would practically be dead. So, what is your pain?
Oh, then it's the 12.
I quit. I cannot deal with you people any longer. Where's my manager? I quit right now.
Sadly,
Something ordered now.
She's like,
I want something ordered now.
Yeah.
All right. Sadly, there are nurses out there that behave like that. Right? It's that person's reality. It's their assessment of their pain. It is a subjective assessment. Right? Doesn't matter if we think they're medication seeking or not. Right? We have to believe that they're in pain. And it's reasonable to give them something for the pain. What we give them is what we can give as a nurse or what the doctor orders. We're not there to, the doctor orders morphine. Who are we to say that they're not entitled to that morphine? Because the doctor is reasonable. Who are we to outthink the doctor? He's got a history on them, but I've seen it happen. I've seen a nurse withhold pain to a person post-operatively because they thought they were pain seeking. And I was the manager at the time. I was the after hours nurse manager, and that guy seemed in pain to me. And yeah, okay, he wasn't rolling around and crying,
Yeah.
but the only thing he had ordered was morphine. I said, well, give him his morphine. I don't want to. Why? Because I don't think he's in pain. I said, same answer. Doesn't matter what you think. If he says he's in pain, it's reasonable to expect that post-operatively he'll be in pain. I want him to have his pain medication. She flat out refused to do it. So I went with the other nurse and I drew up the medication and I gave it to him. He was about to leave the hospital, right? That put him at greater risk, right? We would, if he was an addict, he would have gone and got something off the street, far more dangerous. So it's important that we respect that person's individual right. As much as they have the right to refuse, they have the right to say they have pain. So, pain is so subjective, self-report is considered the gold standard and the most accurate measure of pain. And that's, I looked up for a really good statement about pain, and that's one of the best things I found. It's true. Nurses can help patients more accurately report their pain by using specific tools, and there are lots of tools out there. I like PQRST because I can remember it really easily, because they used to use it only for chest pain, but it's a good standard for all pain.
what's PQRST?
I've answered your question. I paused to wait for someone to ask that because everybody does. Provocation. So, what were you doing when the pain started? What makes your pain worse? Does bending over, touching your toes give you more back pain? So don't do that. But it's what provokes it. So we know It could be muscular. If you're sitting there and you're getting chest pain and you're not doing anything, we've got to worry, don't we?
Yeah.
If exercise makes it worse. Okay, what relieves it? That's just as important. So, does laying back on the chair or laying flat on the bed or laying on the floor relieve your pain? Gives us again an idea of where it comes from, what it could be. What aggravates it? Quality. Doesn't mean you can say, oh, is it good quality pain, mate? No. What does it feel like? Use words to describe it. And I often use, is it a dull pain? Is it a sharp pain? No. Is it a stabbing pain? Because you get a better view of what they're thinking. And it can tell you a little bit about the nature of the pain. Often if it's a sharp stabbing pain, it might not be cardiac. But you still do an ECG anyway. But it gives you a better idea of where you want to go.
Mm-hmm.
Region. So where is it? That's a really good question to ask. I've seen nurses do it. Oh, you've got pain. That's okay. Have a seat. Was that chest pain they were talking about? Yeah. Be nice to know where it is so we can decide if we want to give them an ECG really quickly. I've seen a nurse say, go and sit over there, and the guy's sweating profusely. And I've gone, I think I'll take him inside if you don't mind. Why? He's only got 2 out of 10 pain. And mate, where's your pain? Oh, it's in my chest going up to my jaw. Yeah, let's go.
Yeah. Yeah.
And I did come back and talk to the girl and say, well, perhaps in future, ask them where you've got the pain. Oh, I didn't think it was chest pain. How did you know? You didn't ask. Severity, pain scale. And it's really interesting because it doesn't force you to lie down. Remember, some people are tougher than others. I still remember an incident in ED. I was sitting in there triaging, happy little triage nurse. Busy night, guy in front of me with chest pain. Got him organised. Guy comes up to me. Oh, look, mate, I've cut my thumb. Oh, yeah, you've got a tea towel wrapped around it. Bit of blood on the tea towel. All right, mate, any pain? No, it's not too bad, actually. I went, good, you just sit over there, because I could see the guy behind him was sweating and really quite pale. He had chest pain as well, so I've organised for him to get chest pain. He went to resus, because he was having an MI, the guy behind him. Look, yeah, in between all that, someone came in, what was that about? I never wrote it down, which I should have. Oh, the guy with the cut thumb. Walked up to him, said, how are you, mate? Yeah. I'm Neville, I'm the triage nurse. He told me he had a bit of a cut thumb. His wife's sitting there. She's a bit quiet, a bit pale. And I went, thought she was okay though. I said, are you all right? Yeah, I'm all right. I'm just worried about my husband. I thought, cut thumb, fair enough. I said, can I have a look at this colour on your thumb? And he unwrapped it. And as he wrapped it, the whole thumb fell backwards. It was attached by a piece of skin on the back. And I said to him, a cut thumb? Oh yeah, he said, I cut it on my bandsaw. He said, I was cutting a bit of wood and there's no guard on the bandsaw. He said, but I managed to hold it tight and got the tea towel around it and came to the hospital. I said, perhaps you should have told us you've tried to cut your thumb off. Oh, it doesn't hurt. And he said to me, it's not worse than this one, and he's got fingers missing here, which he did on another saw.
Wow.
He said, this one's probably savable. And he cut through the bone and all.
Wow.
And he still didn't have a lot of pain. So we got him inside. He actually saved the thumb.
Yeah.
He actually saved it. He had his thumb. It was better. He said, better outcome than the 2 fingers. And he came back and saw us. But we got in there, had microsurgery on it and got it all rejoined.
Pain
Beautiful.
threshold.
Had like 95% use of that thumb, which was amazing.
That's a good outcome.
But, you know, sometimes they don't express pain either. Timing. So, what time did the pain start? How long did it last? How often does it occur? And I've had people come in and say, I've got lots of pain. How long had the pain for? 10 years.
Mm.
And I pause and look at them. 10 years. So, is it worse? Is that why you've come in? No. Have you seen a doctor about it before? No. So why have you come in tonight? Because I've got pain. Okay.
Mm.
Do you want something for the pain? No. And you're sort of puzzled as to what you're going to do with this poor person. All right, mate. Do you know what the pain is? No. Sort of up in my shoulder here a bit. And she said it's worse when I move it. And so, is it a different pain than you had it? No, it's the same as I've had for 10 years. Okay, have a seat. We'll sort you out. So are you doing something for pain? I'll give you some Panadol or some Panadol. No, I don't need it really. He said, I'm used to the pain.
Mm.
Okay. We got him seen in the end. He had arthritis in his shoulder.
Mm.
Oh well. But, you know, sometimes it's just that way.
Yeah, they
And
just
you
have
get the other
to
guy
work.
that's the opposite with the thumb.
Yeah,
No pain, she'll be right, mate.
yeah.
So, and it's really important, once we've done all this, that we document the results, what we've asked. And you can put PQRST and describe it down the side. Kids, they use the Wong-Baker scale. So you can tell by their little faces if they're in a lot of pain. Kids are honest.
Mm.
Okay, document. If you use the Wong-Baker scale, tell them that's how you document it so everybody else can document it the same way. Right? So patients' understanding of the pain scale. So you have to describe it to them. They do understand it. You know, I've described the pain scale. They say it's 7 out of 10. They say it's severe pain. That's good. If they say it's 2 out of 10 and it's severe pain, document that. That's what they believe. That gives you an idea of what they think is really bad and what they think is really good. Where they want to be in their pain. That's a rough scale of what nurses classify pain as.
Yeah.
Right, to give you an idea of what mild, moderate and severe pain could be. It just helps us gauge the content of severe, mild and moderate to us. Puts us in our own space about their pain. Okay? Timely assessment following any intervention and response to treatment is really important. Document the patient's response. If it's it's gone to 5 out of 10, write it down there. What's wrong with that? But nurses won't do it sometimes. I think it's important. I do. And communicate it. Tell the physician, hey, what's your Gunner's working? Great. Or, look, I think we probably need to review this medication. 2 hours ago they had morphine and it's still 5 out of 10. So what else can we use? Talk to them about it. They'll certainly come up with another idea. Look, most doctors want you to talk to them and tell them how their patient's going because they don't get the time. Whether it be on a ward or in ED, whether you've got 7 patients to see, you know, they've got 15 minutes to see them in. That was a failed video that didn't work. It was another song. Okay, that's it, guys.
That's it.
Any questions? Any inspired comments? Hopefully it's been helpful.
Take in. Yeah.
Yeah.
Hopefully you'll get something out of it. That's the aim of the exercise.
Yeah.
I think,
Um,
oh, sorry, I was going to say, I think what it's shown you is you just can't go and take a Panadol or take an ibuprofen and
Yeah.
just take it for granted. It gives you a bit more of an
As
educated insight, doesn't it?
Yeah.
Any kind of medication.
Yeah.
And if nothing else, in these talks I want to get across the importance of the 7 rights.
Yeah. Oh, really?
Really.
What was that again?
Didn't get that, did you? Or in your case, the 5 rights. But
I did that on purpose.
I know that. I didn't. If I thought you actually believed, I would have thrown a cup at you or something.
I was waiting for the mouse to fly across.
I had thought about it. But yeah, that's what I want to do. That's what I want to get across to people, and the importance of pain management and being sensible about our
And
approach to
listening, I
patients.
think,
Yep.
because I can give my example.
You've
When
experienced
when I
it.
had my hip done,
Yep.
right, you know what?